This is Renew Education. This is a really simple case that I was just kind of planning out here. This is a case that is very helpful to understand how to use your CT scan for the dentists out there. And this might be something interesting to patients as well on how dentists should be looking at things, but looking at in terms of what's successful, what you need, what you don't need, and why you might need it. So how do you use your CT for just a straightforward case? Is a very common situation where you have a single tooth replacement here on number 19. So let's quickly just go through the treatment assessment. If you know about that, you should take a look on our site and go along with me. But our treatment assessment is basically a yellow constriction, and that's looking at the full arch on upper and lower, not specifically for number 19. Green on a bone, on the bone quality or the density, light green on the facial aspect of the bone, and that particularly is looking at our facial bone on number 19, and then a yellow on the IA nerve. So the yellow aspect on the IA nerve comes up only because I get about that, I get into the 11.5 millimeter range, but the drills I know always go a little bit over. So let's just kind of take a look. Obviously this is decay down into the nerve and non-restorable with a decay down that deep. Patient has a full arch, has quite a bit of dentistry here on the posterior or the back teeth. And here, if we look at this tooth in particular, we're looking at it as, are we going to take the tooth out and do an immediate placement, or are we going to do a socket graft? Okay, so I think of this as a socket graft when I see this curve. When I see that curve, that means if the implant is going to come down the middle, right down here, I'm not going to have any bone left to hold it because we have a gap between here, the implant, and then a gap between here and the implant. And so a lot of the bone is going to go away. So right off the bat, when I see a curve like that, and you can see the top of a tooth here and those two roots coming together, and here's where our implant is, the trajectory of the implant is. And the problem we always have with implants is that they are round, and no tooth in your mouth is truly round. And so you're coming from a round base, but if you're taking out a shape, you want to be sure that you can try to match that shape as best as possible. So our implants are only about 5 to 6 millimeters on their biggest end. There might be a couple of companies that have 7s and 11s, but here we've got this situation where we've got the 5 millimeter digital version here. So here's when I scroll down and see the top of where I put the implant virtually, and you can see that what we call the septal bone here between the two roots is gonna get drilled away. Okay, so you're not going to have a lot of bone. People can drill this, they're artists, they're great surgeons, whatever, and probably secure the implant in. But the problem is that you have so much gappage on both sides, the likelihood of that becoming looser in the next 4 to 6 weeks when the bone becomes very weak is very high. The second problem you have is more initially with the gappage, with bacteria and getting an infection in the socket site. Now you can try to cover that up by doing a graft around that and trying to cover it with a matrix or some sort of collagen or some sort of membrane or some sort, so you don't have possibly the invasion of the bacteria there. But then it becomes very expensive. Those products become very expensive, and do they really help you out? Well, literature says that the bone that is in here that grows through the actual graft doesn't seem to be at the quality that if you had native bone there in the first place. So you either go for one bone healing event, which is an immediate placement of the implant into the socket site, or you wait one bone healing event, the 3.5 to 4 months or whatever the doctor decides that bone healing event would be. I wait 3.5 to 4 months to do it, and then you place your osteotomy. So that's what I would do here, and I wouldn't do an immediate placement, and it has mostly to do with that curved root coming in and hooking around. When you take this tooth out, it's already going to be a challenge there, but let's say you take that out and it's, you know, a really nice socket site, all that stuff, but now you've got this septal bone. So if I were doing an immediate placement in this case, I would be clipping that bone away and adding that bone to the graft material so that you can now have autogenous bone with native cells and growth factors to grow the bone within your graft material, communicating to the rest of the socket bone to say, hey, grow bone here. So I wouldn't necessarily do an immediate implant because I just don't think that that's a smart way to go. So when you clip that bone away, when you go back in to do the surgery, I don't have this bone forcing my drills to find that spot, right? Your drills are going to want to hit there. They're going to deflect off that bone and go at an angle, or they're going to come and go into this socket. You got to remember that these little socket holes 3.5, 4 months down the road are not going to be as strong as the native bone that's already there. So you're stuck with soft bone, hard bone, soft bone. Okay, so if you clip that away, everything is soft bone. So now when you think about having soft bone and you put the implant in, you actually have an area where you don't have any resistance, and it doesn't force you into the area that you don't want to be, which is the front or the back side of that particular socket site. So looking at the side here too, we have a little bit of facial bone. So here's where you get predictive value by doing a graft first. So as we look at the tooth structure here, the tooth structure is here, and you can see that little outline. That's a ligament space, but then you have this really kind of hard bone here. Many times this dissolves away and your graft can help hold it here, but if it doesn't, it kind of will probably melt that corner off. And now if you did an immediate placement implant, you might have an exposure of the top area of that particular implant. So you want to wait and see if you can manage that bone from a shape perspective now, so you know where that implant actually has to be going more accurately based on the dimensions of the new bone that's growing in there. So that's a pretty straightforward case. I can't think of any other real thing that I look at in this case before I start. This is one of those cases that I would wait on the socket graft. I would do a socket graft and wait on placing the implant, and I would also just let the patient know you don't want to be having to do a stay plate or anything else here. That's another thing that people ask me, like, oh, do you have a temporary tooth that goes into this site? And that's a no, because this is a molar area, and unfortunately just going to have to chew more on this side because that's a primary chewing area on this site. So that becomes challenging for the patient for the first and second bone healing event. Once you put the implant in, you're not putting a crown on then either. So you've got, this project is at least 8 to 9 months in my office so that we can assure that the implant's successful first and foremost. Secondly then, or first off, you have the proper bone you need to put the implant in. That's the first bone healing event. The second bone healing event would be looking at it from the perspective of we give the implant the most success for proper healing with the best type of bone around that particular implant as the healing and the bone is going to mature into the site. So that's what we do there, and then the crown is appropriately put on because you've got it in the best position you can. In terms of the other things like the nerve, this is a little bit tricky because you can't really see it all that readily. You can see the foramen here, but you don't see the nerve directly. So what I do with RCT is I go into a very small slice view, let's say a 1 millimeter slice view or less. And so here's where I just kind of scroll through and I follow where that foramen is. So you could see the nerve here going through. on this aspect here. You can see how low that actually goes. And then you have these little channels that kind of pop up here and there. And they're just kind of nutrient canals that you can kind of see and make light of. But when you see where that nerve actually is, it's easy to kind of follow right here. And then what I'll do is take this bar and I'll put it way down here. So now I know that nerve on this site is actually way down here, and that's actually where my nerve is relative to the base of this particular root. So we have a lot of bone here. We have even more bone going down here. So we don't have to worry about where the nerve is. So this is a really, really good situation to be a beginning case for someone to kind of follow through and do a single implant tooth replacement. So anyway, I hope that was helpful. If you have a CT, if you're a dentist or even a patient that is interested in doing these simple single tooth replacements, remember that not everybody's the same, and they don't always just can put the implant and put the crown on. You're gonna be a loser in a lot of those cases. So just be patient with the cases. Be patient. You'll have the better lifetime results that we're trying to look for. So great. Like us on Facebook and subscribe on our YouTube channel and look for our live broadcast. Thanks.